Hi, everybody. It's Dr. Sloan. We are going to talk about chronic and neurodegenerative disorders, specifically Alzheimer's and Parkinson's, which are two pretty common diseases. And my guess is that you've already seen them in your time in the nursing program. Learning objectives is going to be very short and sweet. Discuss the pathophys, clinical manifestations, diagnostic tests, pharmacologic treatment options in nursing care of patients diagnosed with Alzheimer's disease and Parkinson's disease. So Alzheimer's, this is a term that you're familiar with. You were familiar with it before you even came to Gonzaga because it's out in our community. It's now a disease that we're all very familiar with. You've probably had a family member or a family friend affected by this disease, someone that you know in some way. And so it's something that we need to be aware of. This is really a devastating disease, very hard on the person to whom it happens to, and very difficult for the family who are caring for this person. So Alzheimer's disease, or AD, is irreversible dementia, and it's caused by nerve cell death, loss of acetylcholine, and brain atrophy. And bottom line is, we don't really know why people develop Alzheimer's disease. There are some types that are linked to genetic mutations, and you can actually see Alzheimer's in families. If you want to see a really interesting story about this, you could Google 60 Minutes and familial Alzheimer's, and you'll see a story about a family in Italy, actually, whose many of their family members have been hit with a form of early onset Alzheimer's, where people are diagnosed like in their 30s. So that's unusual. We tend to see Alzheimer's a little bit later in life, but can hit people really at any mid-life or older stage. It is the hallmark of Alzheimer's disease is this beta amyloid plaques. And these plaques accumulate outside neurons, and it interferes with nerve stimulation and nerve conduction. These tau proteins accumulate inside the neurons, and they form these neurofibrillary tangles, and that interferes again with conduction, which leads to the death of the neurons. So the beta amyloid plaques and the neurofibrillary tangles are definitely the two hallmark pathophysiologic signs of Alzheimer's. Unfortunately, you can't see those with a CT scan or an MRI, and so the disease is primarily diagnosed using symptoms, history, context, but really cannot be confirmed until death, at which point you would do a brain biopsy and look at those tangles. And the reason we don't do a brain biopsy while they're alive is right now we don't have a treatment that affects really the course of the disease, nothing significant. And so why risk doing that brain biopsy, which could lead to other things like a bleed and infection. And so, like I said, it leads to a loss of neurons, which leads to brain atrophy, and the loss of neurons is loss of synapses and acetylcholine. So that system in there for thinking and for memory, those pathways are being destroyed. Manifestations, I'm sure you've already looked at this, may have even seen it in person, but progressive forgetfulness, disoriented or confused, loss of problem solving and judgment, failure of math calculations. That's a good way to help diagnose what's going on, the ability to conduct even simple math. Behavior changes, agitation, restlessness, depressed or hostile mood swings, emotional or upset, and then progression to nonverbal, non-ambulatory state. One of the things that happens with people who have dementia is their brains at least, are often aware that they can't keep track of what's going on, but they try really hard to keep track of what's going on. And so that mental effort to try to keep things organized and making sense is exhausting. And I think that's where a lot of the um, irritation, agitation, restlessness comes in, and then just flat out fatigue. People just get exhausted. So treatment for Alzheimer's, there are no, like I said, no biological markers. There's no blood test you can do. The only way we can confirm it is on autopsy when we go in and look at the brain. You can do a CT scan and an MRI, which may show that the brain is beginning to shrink, or that there are some physical changes in there, but again, can't determine that that's Alzheimer's until death. And then you want just ruling out other causes to make sure that there isn't something else that might actually be, fixable, curable. So my dad has, dementia, and whether it's Alzheimer's or not, we don't know. But I know that when he was first diagnosed, we looked at a lot of things like sleep apnea and cardiac things to make sure that it wasn't just some lack of oxygen to the brain. And so they ruled all of those things out before they went and made that dementia diagnosis. Treatment, this is where your nursing care really comes into play, is ensuring safety. That is probably numero uno. From the standpoint of making sure that they, are either have proper supervision or have safety aids in place so that they can't injure themselves. It's not uncommon for people with Alzheimer's to do things like leave the stove on, leave a flame going, maybe do something with a cigarette or a lighter that's just would normally be considered sort of careless or irresponsible. Maybe driving when they're not able to drive or not competent to drive, trying to do things like climbing on a ladder or some kind of physical thing that puts them in peril. And then the other thing is just maintaining or improving their general state of hygiene, nutrition, and health. That in and of itself is going to be a challenge. They may not want to eat. They may not remember that they've eaten. They have difficulty with energy to get up and go out and take care of their bodies. So again, I would say that as a nurse, your primary responsibility is going to be managing and protecting safety and providing memory aids if possible, and then helping them to just optimize function within whatever capabilities they have. I think one of the things that has been really not fun for me, but has been satisfying for me, is to try to help my dad find things that he likes to do, that he's good at, that occupy his time. Otherwise, he sits around and he worries. He has a lot of anxiety. And so he likes to work with his hands. So things like, I bought him a bead loom. And I think that's getting more and more difficult because the holes are little, there's threads to wrap. Now he's doing leather work. So he's always liked making things with his hands. And he spends hours and hours doing that, which has been really great for him, and I think really great for my stepmom. And then pharmacologic treatments as well, and we'll talk about those. So probably the medication that's best known is Aricept. Aricept is donezepil, and it prevents the breakdown of acetylcholine in that synapse. So it increases the amount of acetylcholine, and it results in increased nerve impulses. So side effects, nausea, diarrhea, can cause a slower heart rate, and it can lead to improvement of memory in 1 to 4 weeks. So this is another teaching point for your patient that taking this medication is not going to make things better tomorrow. It might make things a little better in a few weeks. So a lot of teaching to be done with the family. So it needs to be taken every day, even if it seems like it's quote unquote not working. Another medication widely administered for moderate to severe Alzheimer's is NMDA receptor antagonists, and the prototype for that is memantine or Namenda, and it blocks glutamate activity, which may slow progression of the disease in moderate to severe AD. Notice that neither one of these drugs are curative. They in no way fix the underlying problem. They literally just help with function, day-to-day function. And that's really the, aside from a cure, which would be wonderful, this is the goal, is to allow them to be as functional as possible. Okay, Parkinson's disease. Parkinson's disease, again, is a disease of the brain, just like Alzheimer's disease, and it can lead to what we probably think of the most as like a tremor or a little head wobble. It can lead to rigidity, postural instability, and bradykinesia, which means slow movement, like shuffling of the feet, right? A little shuffle that happens. So probably the poster child for Parkinson's disease, not by his own choice, is Michael J. Fox, who was in the movie Back to the Future. He was diagnosed with Parkinson's at a very early age. He was 29 when he was diagnosed. Usually this doesn't happen until someone's over the age of 40. So his case was unusual, and he was just such a bright, smart, funny, very successful actor. I think a lot of people just thought, wow, how could this happen to someone so young? And he's really, done a lot to raise money for Alzheimer's, or sorry, for Parkinson's. Thank goodness he doesn't have Alzheimer's. So pathophysiology, there's degeneration of the basal ganglia, which leads to dopamine depletion and a relative excess of acetylcholine. So it causes fine tremors, motor dysfunction, coordination problems. Again, we don't know what causes Parkinson's. So there's two types. There's a primary and a secondary, but I just want you to know primary, which is onset after the age of 40. It's more common in men, and again, this progressive degenerative disorder of the basal ganglia in the brain. Here's a little link to a short video about Michael J. Fox, and I think it will be enlightening to look at. It was done 4 years ago, so I'm sure his symptoms have progressed even more since then, but causes bradykinesia, abnormal slowness of movement, and sluggishness of physical and mental responses, monotonous speech, tremors in the hands and fingers at rest. They might do something called pill rolling. So imagine if you had a pill in your hand, in your fingers, right? And you were rolling that pill back and forth across your fingers with your thumb. That's pill rolling. And you'll see tremors that increase when they're fatigued, rigidity or jerking movements, restlessness and pacing, blank facial expression. I would say this masked-like faces, or facies, sometimes they'll call it, is kind of, again, another hallmark sign where they just don't have much expression on their face. And of course, that can be misread by people as some, window into your soul of whether you're happy or not. And for someone who has Parkinson's, that's not true. It's just their body sort of belying what's really underneath. They can have drooling, difficulty swallowing and speaking, loss of coordination and balance, and then shuffling steps, a stooped position, so back hunched over, and a propulsive gait, which means almost like shuffling, but sort of walking on their tiptoes. It's kind of like if you ever watch a toddler when they're starting to walk and they sort of lean forward and then they have to keep, stepping in order to not fall. It's sort of that kind of a gait that you're looking at with someone with Parkinson's. So the medication for Parkinson's is cogentin, benzotropine mesylate, cogentin, and it's an anticholinergic. It restores balance of neurotransmitters in the CNS to reduce rigidity and tremors, Parkinson's. It's contraindicated in people who have angle closure glaucoma because it makes it worse, myasthenia gravis, bowel obstruction, because again, myasthenia gravis is a weakness issue. And if this decreases tremors and muscle activity, it's just going to make that worse. And then bowel obstruction, same thing. Don't want to. This is like, rest and digest kind of issue. So disorientation, it can decrease some of their Parkinsonian symptoms, like the mask-like face, the rigidity, shuffling gait. So you'll have to ask your patient, and you may even notice just by looking at the patient whether or not they feel a difference with it. But it's going to give them dry mouth. So you want to give good oral hygiene. And then avoid use of machinery or cars if alertness is impaired. Okay, another med that is frequently given, this has been around forever. I actually remember doing a drug card for this when I was in nursing school, and the medication is Sinemet. And Sinemet is carbidopa levodopa, which is a synthetic dopamine. Basically, it's a precursor to dopamine. And so carbidopa prevents levodopa from being metabolized before it enters the CNS. So then hopefully that, increases dopamine levels. There's a recurrence of Parkinson's symptoms that appear after a few years of levodopa therapy, so it's reserved for patients with significant symptoms. I think this is an area of drug treatment where we are beginning to make some serious progress. There are some new meds out on the market that you aren't going to learn for this particular lecture, but show a lot of promise. Let's see here. So you're basically going to, again, monitor for, efficacy, relief of symptoms, take at regular intervals, meaning don't take it at like 7 in the morning and, 4 in the afternoon, take it at 7 and 7. Do you want to try to get that nice drug, coverage all throughout the day and the night? You want to change positions slowly because this can cause some orthostatic hypotension, and then don't administer it with a high protein meal. I think because that will bind to the medication and leave less for absorption. All right, my friends, that's it. I hope that helps. Just those two diseases and the information that we did on stroke.